BioEthx Café. Café BioEth. Digital consult management. Burden or benefit?
I've worked on bioethics now since about 25 years ago. I've been working with the Veterans Administration in working with digitizing the bioethics consults. It started when in the United States, Veterans Administration had a lot of public complaint about how some patients may not have been treated the best way. And so they initiated a way that they could track all the concerns that were coming up in bioethics and track that out. And so they reached out to my organization to, I was running a digitization company at the time, a data science company, to look at ways that they could track these consults and find out how they could practice medicine better to make sure that somebody wasn't being left behind, right? So by 2006, we had developed a whole process for documenting bioethics consults in the military veterans in the United States. And we were able to launch that out in 2006, along with the advent of the 4 pillars of bioethics publications that came out at that time, and from Beauchamp and Childress on the 4 pillars for bioethics in 2006. So at that point, we were able to implement better practices in the military hospitals for that. So our processes and our data collection and digitization happened initially at the Veterans Administration hospitals, 150 hospitals and more nationally, and implementing the integrated ethics center at the VA. And then we moved on to Harvard Medical Systems, who also wanted to implement it. And we talked to Kaiser Permanente in the United States, who also wanted to implement it. Having said all that, I think Dr. Ellen Fox took over at about 2006, used some of the software processes that we had implemented to expand it into not just clinical ethics, but also organizational ethics and other areas. So I'm giving you this background because a lot of times when we sort of happen to be in the middle of bioethics practice, we have so many sources of information that have now come up, and ideas and thoughts, that sometimes it's hard to say, okay, do I have to create my own way of doing it, or can I learn something from things that have happened before that other people are doing? So I think that it becomes important for us to share some of the lessons learned and best practices that exist out there. I think then of course there was the emergence of the American, the Association of Bioethics and Humanities that has occurred here. This is the association in the United States for bioethics, that I think they have just completed their conference, maybe. Some of you might have been, I don't know. And so this is something that they're constantly looking at. How do we do this? Does it make sense to digitize or not? Having said that, a lot of centers have their own templates that they want to follow. And I wanted to share with you some of the things that we've learned over the years. There's a Dr. Kelly Armstrong who created a coding system that she calls ACSES or ACES. And Dr. Kelly Armstrong currently is a director of Inova, which is a hospital system in Northern Virginia. And she's come up with a coding system so that you can catalog cases in a standard way. And where that helps is if you're sharing information about things that you've learned, if we can all start using at least some basic things that help us compare center from one center from another, and how did you handle certain cases, it helps us understand what are the best practices? How should we teach bioethics? What are the processes that should go into play in clinical ethics, in organizational ethics, in research ethics, right? And bioethics committees, where that's more of a retrospective. A lot of times it's a retrospective, but sometimes on complex cases, bioethics committees are sharing information or trying to come up with sharing ideas or thoughts or opinions on different ways of handling things. So it was interesting for me. One of the things I wanted to do is talk to you a little bit about what we've done, but I really want to learn from people who have signed up to this meeting about what you're doing in terms of collecting information, documenting it, and tracking what has happened, and being able to look back and learn from that. And one of the things that we're doing right now is to help us with that, we're adding some of the new technologies to do some research, some AI technologies into some very basic data collection things that we already have in place. I wonder if any of you who are on the call would like to share what you do, how you collect information. So I'm going to open it up for that kind of discussion for right now. I'm going to show you what we have. Right. This is what we have. This is a process that we follow in a clinical ethics process. This was developed over the course of probably 10 years, initially 6 years with the military ethics, and then with Harvard Medical Systems and the Boston Children's Hospital, we were able to add and modify some things. Essentially, an ethics concern comes to us. We receive this request, and we document who made the request, what's the relationship. Usually, it's about a patient or a specific situation. Sometimes it's not. Sometimes it's a difference of opinion between the physician and the nurse, where you're causing some kind of moral distress. Sometimes it's just the way you're interpreting policy. But let's talk about a clinical ethics where the locus of the concern is the patient. So you receive the request and you determine, okay, who are the stakeholders? So somebody calls in and you want to know what's the situation? It's this patient. Who are the stakeholders? Who's the clinician? Who's the nurse in charge? Who are the people who are involved in this situation? And so we collect that information, we document that, and usually that comes to our bioethics office, and then they call in somebody who is registered as a bioethicist in that facility, and that person calls back and inspects the facts and may talk to the clinician or the nurse, and may then meet face to face. And the American Society for Bioethics and Humanities recommends on a clinical ethics consult that you actually go and see the patient and visit directly to just get a very good idea of what's going on. So that you're not just getting the one side part of the clinician, physician, or nurse. So this is the second part is the inspecting of the facts, because you receive this call, you find out, and then you start looking, okay, this is the situation, this is the ethics dilemma as it's being presented, and what are the sources of knowledge that will help me look at this ethics dilemma. So a lot of times the ethics dilemma has to do with the patient or family members not coming to agreement with the clinician about a course of action to be taken. And so there's a conflict going on. And so what do I know about this kind of case? What's the clinical aspect of this case? What is the patient situation with this case? And who are the stakeholders? What is the religious affiliation or the beliefs of the patient? Who's the surrogate, and so forth? And we'll look at the tool and we'll have more detail on it. Once you look at all these sources of knowledge, it's not just the situation, but also a lot of times it's if you have Catholic hospitals, for example, or Seventh-day Adventist hospitals, they might have some policies that impinge on how you're looking at, how you're viewing that case. And also there might be legal aspects of how you're viewing that case. And the clinician a lot of times may have a conflict between what are the best practices in this kind of clinical discipline versus maybe that's a conflict with the hospital policy or the law. It's just the interpretation of it. So you have all these things that you're going to look at, and then you assess the ethically and clinically viable alternatives that you have, and you do so by looking at the 4 principles of bioethics. They're doing the right thing, doing the not the right thing, but beneficence, what's good for the patient, non-malfeasance, autonomy, and justice, right, or fairness. So you look at those factors as both internal to the case as well as external, because there are some a lot of times there's financial stresses that are going on, both from the patient and family members, or a consequence of a particular process or particular plan of action might have a financial consequence that's disastrous to the family members, but may be clinically advised, and then what are the things that you can do to alleviate that. So assessing the ethical and clinical viable alternatives really has to do with looking at all those things and coming up with what sounds like a good clinical alternative to what the clinician originally recommended. Is it maybe there's more learning that needs to happen from the patient and surrogates to understand what's being recommended, and then maybe there's some very strong sense of autonomy, maybe like in the case of some religious practices where they don't like blood transfusions, and or they don't think it's right, or it's just terrible for them to have a blood transfusion, and there could be an alternative, and maybe the risk is different, and this you want to assess the benefit and the risks and come up with those alternatives. Then you want to communicate those alternatives. First, you consult with the clinician, say, look, this is what we think, and then you come up with a strategy on how to communicate that to the patient and stakeholders to come up with a consensus on how to proceed. And then once you have that consensus, you can then close that consult. I'm making it sound easier than it is sometimes, but it may be more complicated than it is in some cases. But once you finish, but I just wanted to share with you that that's all the things that either you do it very rapidly or very slowly, depending on the complexity of the case. And then you close that consult, and then you can have a follow-up with a QA process of contacting the stakeholders and finding out if they thought it was handled to their satisfaction. That's kind of how the processes that we looked at, and how we have to collect data depending on the complexity of the case. We can collect, there are some fundamental things you want to collect, but then there's a lot of other concerns that you want to document that may or may not be relevant on a simpler case that could be relevant in a more complex case. That is kind of how we do it in the VA and the Boston Children's Hospital, and I think Kaiser does something very similar in the clinical process.
I was debating on whether to write it down or just mention it, but I was going to say I haven't had any experience being able to use such a framework, so that's why I don't have anything to say about it. But yeah.
Okay. Yeah. And then some of you are in the learning mode, and so I understand that. All right. So what I can do is I can move forward. Is anybody here in a hospital setting or a clinic setting or a nursing home, long-term care setting, palliative care, or anything like that?
Carmen, can I just raise the fact that we've been involved for some time now, and you visited the UK, and you went to a hospital in the UK to discuss how they actually functioned and the methodologies they used. Is it worth you talking about your experience with outside of the US?
Well, I thank you for sharing that. I think that I think it might be more interesting for them how we collect data and what kind of data we collect, and how this could be helpful, rather than what other hospitals we've talked to. If you don't mind, I mean, we have talked to Great Ormond Street in England, but I'm not sure that is what folks here want to know. Would you like me to show you the software tool that we use for collecting data? Would that be helpful? Can you just give me a sort of a thumbs up or?
Yes,
Okay.
that would be helpful.
All right, thank you. Oh, great. Thank you very much. Okay, so let me then move on to that. I was hoping to learn from you, so here you are turning the tables on me. Okay, let me show you what we've done and then I'll share with you what we're doing, which is coming up with different versions of what we've done. So what I'm going to show you is the planet, all right? And what we're doing now is we're having a platform that allows you to select a brief road trip to documenting, and then also another workflow that supports the medical research. Right today, we're going to just look at the clinical research, the clinical consult. Right. Let me get to sharing the place where we're at. Okay. I'm going to briefly talk about and I already talked to you about how it's laid out, but I will share this. I want to say that I'm sharing this screen that has these 5 things stated in a different way. Somebody requests a consult, we engage stakeholders, we assess the dilemma, we do some research and find out the alternatives, we recommend a plan. And then what I didn't say to you is that once at the end of this, we can issue a patient note, we document the outcome. That patient note is something that can go into the electronic health record, or it can be printed out to put in the paper file folder or in any other way. So this is what we're going to look at because that's how we do it in our software. So I'm just going to stop sharing that and I'm going to go into what our software looks like. All right, so this is our software. It's called BioEthx with an X. In CMS, Consult Management Platform, CMP, I guess, Consult Management Platform. And this is the main menu. It allows us to put in a new consult, list what consults we already have collected, and so be able to drill down on what we already have so we can review what we've done and see if we can learn from that. We can have attachments to the consult. So the consult is the whole event of having managed some kind of dilemma. The attachments are documents you want to add. Could be informed consent, could be advanced directives, could be a reference material, an article, or anything like that. We have a way to search through the whole database about using keywords, about giving me all the cases that are end of life, give me all the cases that are patients that are Jehovah's Witnesses that don't believe in blood transfusion, give me cases that are neonatal situations or people with disabilities and so forth. And then reports is just a whole bunch of reports that can look at the information that you've collected in many different ways, the distribution, where this happened or what kinds of cases there were. So I'm going to go and show you my what happens when you get a new consult. So let's get a new consult here going on. And what we have here is a way to look at whether the consult is a clinical consult, has to do with a particular patient or a situation with a patient, or it's an organizational consult where we're looking at the ethics concern of how we interpret a particular policy within my organization. And we are in the process of adding 2 more workflows here. One is the ethics committees, because a lot of times organizations handle it as ethics committees, and then medical research. So those 2 are coming up soon, but we're going to, for the demo, we just had these 2 there. Okay, we're going to go into the clinical one. We're going to say, okay, this is about Mary Jones. And then I create a new consult, right? I'm creating a new consult. And here you have these are the things that we talked about, right? So we define what the consult is about and what the ethics concern is about, and then we assign it to a bioethics consultant, right? So we define the situation, the patient, the request, the concern, and then we refer it to a consultant. The consultant then takes it, and they're looking at all the information, who has authority to decide for the patient, whether there's a surrogate or not, what's the background of the patient, what's the clinical diagnosis, what is the recommended course of action by the clinician, what's the ethics issue? Well, okay, now we have this, they're being told that they're going to be, there's no hope for them, and they're going to go to, another a respite home, or some other place, and then they don't agree, or any of these things that might create an ethics issue. So that's this part. And deliberate is when you say, okay, now we're going to talk to the decision maker, we're going to do the analysis, we're going to look at the options, we're going to look at the legal things that impinge on the case. There's another thing. A lot of hospitals are religious hospitals. They're either Catholic hospitals or Seventh-day Adventist. Those are the most popular ones. So those are also things that we can codify and tag a case with the fact that it may have an impact on certain regulations that are legal regulations or policies that the hospital has because of its denomination. So we look at all those, and then we come up with alternatives, and those alternatives are going to have risks and benefits, and then we're going to make a recommendation based on that, and then we're going to take the steps that talking to the clinician, find out if this is acceptable, preparing to inform stakeholders. This is the documentation, communication. Now, during a case, you might be hitting this inform quite a few times, not just the last time, but you might be talking to family members a number of times. You might be talking to just the surrogate or just the patient, but in many cases, stakeholders are very important. Family members are very important, depending on how the patient feels about those family members, if they want them involved or not, or if there's a dispute about who's the surrogate. Now, sometimes we have disputes about who's the surrogate and what are their roles. And so sometimes the surrogate needs to have some time to learn what is their responsibility. So inform takes it's really a collection of meetings you might have. But the last meeting is where you communicate, here's your alternatives, how would you like to handle it? This is where we're at. And then you come up with a consensus, and then you document that, and then you finish. And then when you finish, you are going to tag this consult with reference codes that's the coding system that we have to say what kind of consult is it, what are the resources that were used to conclude this consult, what consultants were involved, how much of their time did it take, and then the final thing is, do you want an evaluation of this? Do you want a QA of this? And some facilities always want a QA, which is the review part, the evaluation and the follow-up on the consult. Were the stakeholders satisfied with how it was handled? Were there any system issues that we should be aware of so we can learn from this and do it better next time? So that's what it is. So we have these menu items, and I just want to let you know, one of the things we did is you don't have to be going in this order, and you don't have to fill out everything that's in here. And you can go into different orders. You can say, okay, I'm on the finish line, but I forgot to put in what we did for the deliberation. I forgot to put in what I did to assess, and I'm going to do it before I finish. So you're not obligated to do everything and document everything in a certain navigational way, which it makes it easier. The other thing we're doing is we're adding a voice activated thing. So a lot of the things on the deliberation where you have text boxes, you're going to be able to go in and talk to this is I'm showing it on a PC, but you could have it on iPad. All right, you can have it on an electronic device, and so you could then hit a button that says read it. I think I've made my button disappear, but there's a way you can go here, and then there you can just even speak and say there's a keyword that says okay, listen, and so it starts transcribing what you are talking about, and then you can go back and edit it and correct it because it doesn't always capture every voice the right way. So those are the rules, and this is what our software looks like. So I'm going to quickly go back and look at this menu item because I'm going to show you that once you put in this consult, it'll be in your database. And here's what it looks like when it's in your database. It looks like these are all the consults that I have in my demo instance. And I'm going to look at this. Oh, I want to tell you that the consult number is something you'll never remember necessarily. I happen to remember because I'm doing Jane Carter a lot. But there is a way that you can put in a synopsis, right? See this field called synopsis. When you create a consult, you can put a synopsis on it at what it's about, so you can go back and find the consult just using the keywords. So you don't have to remember that it's demo 18008. You can put an alternate name to it that it's yours and that you're remembering. Okay, so I'm going to go to demo 18. You see the synopsis here is where somebody's writing this, but you could use this. This is a text field that you can use for many purposes. You can say the patient with 12 children, or you can say the patient with this that came in on Christmas, or you can do whatever it is that helps you remember what this case is about, so you can go back and find it fairly easily. Okay, Jane Carter, you can see how the information for Jane Carter was filled in. Here's the ethics concern. The patient was advised by her GP to undergo genetic screening as soon as possible with the pregnancy due to the family's medical background. The concern is that if the tests find any imperfections, whether or not to terminate the pregnancy. The parents of Mrs. Carter are Catholic, do not agree with abortion. Mrs. Carter was raised as a Catholic, but Dr. Sidney Rose says that the risk to the patient is too great to endure the pregnancy and labor. Okay. So I think you can put coding here, or you can decide not to put coding until the end. So I'm going to skip that part. And then you're going to assign it, because we're here, we just received this concern. We're going to assign it to a consultant. So this is where you go and look at the information sources, what you're going to look at. These are the stakeholders. Here are the stakeholders, and these are the people who are involved with this patient that maybe you need to get in touch with. And so it allows you to put in who these people are, what their relationships are, what's the contact information so I can call them up or email them. And then I'm going to talk about what other sources of ethics knowledge I need to consult or that I have consulted. I'm going to talk about the patient's decision-making capacity. Sometimes a patient is just temporarily doesn't have decision-making capacity because of their medical condition. It doesn't necessarily mean that they never have capacity, but that the doctors determined that they couldn't communicate with the patient for whatever reasons that is. So you put the surrogate information in here. Any comments on that? Advanced directives. Anything that has to do with the any informed consent that are on file, you would want to put that in here, and the ethics issue to be addressed. On the deliberate side, I won't go into all the details on that, but you can just say, okay, here's my analysis. Here's how it looks like when I look at the 4 pillars on bioethics. And we're going to make this a little bit, expand on this a little bit more. But for now, I'm just going to show you what the workflow is. And then, of course, you'll have a consultation process, and then you're going to communicate that back to the stakeholders. Once you have done that and you've decided that along with getting the buy-in from the surrogate or the patient and the clinician, this is what you've decided to do, you might want to then generate a consult note, which gives it to you in a sort of a narrative form, what you have been putting in as a report. You can then edit this report before you generate it or put it, and you might have written things in here that, you just put in things, you're going to review it, and maybe you want to say less or say more or whatever you want to do before you generate the report. And then you're going to export the report, and you can export the report in 2 ways, actually 3 ways. You can export it as a printed report. That if you're holding paper files, you printed report, put it in the patient file. You can generate it as an electronic record with HL7 tags that tell you what these different fields are, or you can generate it through what we call an API or a bridge between this electronic record and the electronic patient record. So depending on what electronic patient record is, we would work with you to make this go straight into the electronic patient record that you want, right? So right now, the most popular ones are Cerner, which is now Millennium, and then Epic. So I'm going to close that. And one of the things that we wanted to, so the full report is just simply the data fields, right? It's a more extensive report. It's not, you can say, I only want these fields in my patient record. You can also generate a full report, which is everything that you put in regarding this case. This is everything.
Can I just say something, Carmen? I don't know if it's the same for everybody else.
Yeah,
I'm just seeing a blank screen when you pressed on the reports.
Oh, thank you very much.
I'm not seeing anything.
Well, that's important.
Sorry, it was just a white page.
Let me see if I can get it here. Do you see it now?
You're just loading up. Oh, there we go. That's great. I'm seeing it. I don't know if everybody else is.
That's what happens when you are in this electronic mode, because you can't see the other people's screen, right? This is the full report.
Now I can see it. Thank you.
Okay. Right. So I'm going to go back here. So that what you missed then is the patient note. It's just simply a subset of this thing. And you can edit it. I mean, you can change any text that you have here before you export it to the electronic patient record. Okay, so that is that part. When you go into finish the case, one of the things that you see here is that you can tag several things to it. You can say the type of ethics intervention it was. Can you see the drop down?
Yes.
Okay. You can say the locus of concern, which is what was the subject of the concern. Sometimes it's the family physician or patient team or patient physician. Who are the actors in this dilemma, and then the complexity. So you can tag it with that, so that when you do reporting, you can select out all the cases that had this kind of locus of concern, or you can just look at all of them, or just the ones that are simple or the ones that are complex. And then the thing that is here, which are these codes. Oh, is it a pediatric? This is very important, whether it's a pediatric case or not, because it makes a big difference on how you look at it. But anyhow, and if you had any other thing that you wanted to look for, when you sign up for this, you could say, I also want to know whether I'm dealing with somebody with disability, right? A physical disability, or a mental disability. So you could do that. You can add those things in. And then the codes are, as I said, Dr. Armstrong's codes, and this is what the coding scheme looks like. I want to give you a minute to look at There are 9 sections in this. The 9th one is organizational ethics. I'm going to leave it here so you can look at it for a minute. The idea is you would check on the things that apply, and it would put those codes, tag the consult with those codes so that you could later on, for example, look at anything that has to do, if this said moral distress, you would tag that in. So some people, I say moral distress because it's something that I have addressed recently. So I'm going to share this with you. Some of you have said that your hospital or your clinic or the place where you're at, you're not in a place where you're dealing with this. So I'm going to tell you what I learned recently is that sometimes you'll have a nurse that knows the patient very well, and the clinician and the physician usually comes in some of the time, and depending on the personalities that are involved, they may or may not have communicated very well between the nurse and the physician, and the physician recommends a course of action, and the nurse is trying to say, I don't think that's right for this patient, and the physician doesn't misses it or doesn't recognize that as a relevant thing. And then you have created a moral distress between the nurse and the physician on a particular case with a patient. And so that's the ethics of that particular thing. The ethics issue is that moral distress. This one of yes.
Question. Is it possible that you could have a situation on a single consult that would require documenting 2 or more of these codes? Say, for example, an end of life, and I'm just picking an end of life and something from professionalism,
Right.
safety or security. Could you have a code, 1 or more codes from each of these 9 groups, or is only 1 code?
Well, that's a very good question. I'm glad you asked that, because what you can do is in the current mode, you can select up to 3 codes. And some of these,
Okay.
yeah, so why 3? Because what we're trying to do is to funnel it to where you could, there's always multiple dimensions to things. We want to funnel it to 3 codes.
Okay.
But it's only because Dr. Armstrong, in her 20 years of doing this, has found that 3 codes are sufficient to define the ethical dilemma. But the other thing is that you can, under each one of these already codes, see, this is like section 1, right? Remember how I showed you that this is right here, decisional capacity. You can have subcategories if you want under these for your organization, and we would put them in so that when you are coding it, if you wanted to have a finer definition of that, you can. And so that's what this is. This is if you had said, in my organization, decisional capacity, I want to break it out more, we would have put it into the system for your version of it, and it would show up here.
Okay.
So it would be able to do a drop down here, and it would show you what those things are. And this is all for purposes of being able to retrieve the information later on as the aggregate of all the cases that you've done, and seeing how you have handled it in its aggregate.
Okay, thank you for that.
Then you can say, show me all the cases where there's decisional capacity and contraception, or there's decisional capacity and therapeutic misconception. So you can do that reporting with multiple variables like that. And then here you can put in how much time did you spend and what consultants were involved. And of course, this is a demo, so we don't have all the consultants that are available in your organization. But if this was your particular instance of this application, then we would put in all the people that were appropriate. And there's a module for the administrator of the documentation platform that is going to be able to assign people who are allowed to go into the system, give them authority, give them credentials, as well as saying who's a consultant available. The good thing about this system is that if you had a subject matter expert outside of your organization that you wanted to send them a synopsis, you could send them. Remember how we said, send me, show me the report. You can take that report and attach it to an email and send it to a subject matter expert, or you can invite that subject matter expert to come in, and you could define, they can only look at this case, or you can restrict what they can look at. And so it's important to note that this is, the software is going to be HIPAA compliant. So if you ever export anything or do anything like that without the right authentication, everything is, it hides what the patient name is and actual date of birth. It'll keep the age, but it won't have the date of birth, so that we are sensitive to privacy issues and making sure that we're HIPAA compliant. Okay, I think that's just a general thing. I don't want to bore you further. I will tell you that if I go back here on the menu, just one thing, I guess I'll tell you one more thing that I think is important, is that there is a way for us. Can you see this? Can you see this particular screen that
Yes.
says consultation reports? Okay. And so what I can do is I can report on the data that I have. I'm going to have clinical information, and I want to say I want all my records, and I'll say next. And then I want a standard report, and it's going to tell me, in this case, it's going to just give me a percentage distribution on the different type of things, right? What's the topic? What's the professionalism? Those are the 9 domains you saw in the thing. This is a very simple one-way distribution, but you can have all sorts of other reports, and you can also export these to an Excel spreadsheet if you wanted to do more manipulation, or attach it to a reporting system to do pie charts and so forth. So you can do better reporting with this. But this is what the raw reports are what you're seeing right now. Okay. Are there any questions or concerns or thoughts that you have on this? I see that there are some things in the chat. Don't work in healthcare, but interested. Okay, thank you very much. Okay, you can unmute yourself. Anybody who wants to have a question answered. Confidentiality while using digital records is HIPAA compliant. It is hosted, cloud hosted app, a platform that's cloud hosted, and that is compliant with the strictest Department of Defense regulations. So it's on Amazon. It's on an Amazon cloud.
I have a question.
Sure.
Given that there's, again, mine is not so much on the confidentiality, perhaps on the storage side, because to my understanding, you guys have that, well handled. But what I'm particularly curious is, especially in the age like now with large language models and all that sort of thing, and big data sets being crucial for, the evolving industry. I was kind of wondering if there were any plans or thoughts about incorporating some way to have this kind of data set be used to train in some way. And I'm not sure how it is with clinical data sets, but there's definitely, much potential for, to leverage this to kind of just create automatic tools as a sort of, like, as was mentioned, like a body of knowledge for bioethicists everywhere. And there's fantastic potential to have, personalized, consult directions for how to resolve things. And there's just a lot of potential here. And I'm curious as to know if, like, what that could look like.
Sure. One of the things that is very important on digitizing information on your consults is that you then, so it's not just putting it in digitally. It's actually organizing your information in such a way that it is easier to understand what was the initial ethics concern versus the final resolution. So when you are documenting it in an organized way, such as this tool or other tools might lend you to do, what you're basically doing is creating a standard. And so if we, as a society or as a group of bioethicists, can agree to tag with standard codes, we can start creating a bigger repository. So some people have said, I have a library of cases. This is really great. But what they really mean is they have a series of consults that they have done that have either been published or not, that are the stories, are the narratives. Well, the narrative is fine, but understanding how that narrative evolved during the process and what you did to get to that narrative is what is going to help us in training and research, right? So if I can take the published consults, my consults from my facility, and maybe the people who have a bibliography of consults, and I can organize that information in some kind of way that allows me to drill down. I can then train my artificial intelligence agents and the tools that exist in artificial intelligence to give me some idea if there's this clinical kind of situation and the patient has this kind of sentiment about it because of their background or age or whatever other concerns, then what is the best alternative that I can have clinically and at the same time that I can get buy-in from the patient and preserve their autonomy. So what you are saying is very valid. We are still in the infancy of this until people are willing to do that extra step of documenting things systematically, sharing that, coming up with a common way of storing information and sanitizing it so that we don't have any HIPAA compliance kind of things. We're more interested in training and research. We're more interested in the aggregate, not so much that it's Mrs. Roderick that had this particular situation, but that there was a woman in this age group that in this circumstance that had this information, and that there are 50 or 100 of these kinds of cases. So I think it's interesting that you mentioned that, because I think that's we're at the dawn of this, but it's going to hit us very quickly because AI is happening rapidly. And the other concern I have is that everybody's so keyed up on AI that they're starting to acquire AI solutions that are not sensitive to bioethics. So one of the things that we have is that we've been working on this for 25 years. So we have a 25-year history with it. We have been adopting AI. We have to help us do the research and to help us assess what could be viable clinically, as well as with patient autonomy. So we're able to provide a better guidance or consulting to you. If you have a tool, we can consult with you and say, let me take a look at what you have. Have you thought about that? But I think more importantly, as a community of bioethicists, we have to come up with an agreement of what kind of coding do we want to have and what kind of digitization is important and what could work for a very simple thing. So I don't have to go through all these. I showed you the whole thing. But if you had a very quick, a bedside consult, you might want to just have one screen to put in some basic information. Any other questions or concerns or comments? Okay. Well, thank you very much for attending, and I would like to encourage you to sign up and come to our next event. We usually don't do digitization. We usually talk about some of the conflict areas that people encounter. So, but I think as we go into more and more concerns about artificial intelligence, somebody yesterday approached us with the ethics of artificial intelligence tools that clinicians are using to provide recommendations to the patient as to alternative treatments. And I think that's another area that I think will benefit from looking at what are the treatments that were suggested in a particular case and how did those fare with engaging with the patient and their representatives. So I think it's all tied together, right? So we should work together on this, and I'm very pleased that you have decided to join us today. Thank you very much.
Thank you very much, Carmen.
Okay.
Patient.
Any last minute questions or happy? Otherwise, we'll just go. Thank you very
No,
much.
yeah,
Okay.
thanks for the wonderful presentation. I, in particular, was thinking, yeah, so it's mostly about standardizing the data we have, that's the real big issue at hand.
Well, I think that if you start by capturing it digitally, we can work on the standards,
Mm,
as well in parallel, but not, as long as you document it, we can then go back and retrofit it. But of course, it's ideal if we have some kind of standard way of capturing, but we'll move in that direction.
understood. Thank you.
Mercury, did you have a question or a concern?
It isn't really a concern, but it's a comment. From where I'm standing from, we would be dealing with the different kind of questions in there, not necessarily the same kind of context. Uh, as for the question which was asked, I think it has benefits and also burdens. Uh, of course, the benefits outweigh the burdens. The benefits include the standardization and being able to trace things, and there's also educational and research value. And if you need to use AI to be able to, in case we get to that place where we have standardized data, then it can be able to feed into predictive analytics
That's
or
right.
AI tools. However, it is the way it is structured, it is almost an administrative overload in terms of how many areas you need to input data.
Oh,
And of
right.
course, yeah, and of course, I do think the codes which you gave us, they're good. But then I think you might find that we need to have much, much more. There might be underutilization. Maybe we need to have more codes. You don't know.
Mm,
And the way it is right now, it would work well within a high income setup or a Western based hospital based consult, but not in a resource limited or community setup. So there's some things which maybe can be added in case somebody wants to adapt it. And maybe my major concerns would be, the risk of losing empathy or nuance because, you know, um, we are in a checkbox or tick box kind of setup. So there are those small things you might not be able to see, like the way when you're speaking to somebody, you might not be able to see somebody who's telling you yes or no, but their body language or expression is saying something different. But I
that's
guess we can't have everything. So it's just how can we improve it because it definitely, adds value to to bioethics consults and yeah.
right. Right. So, Mercury, I think you could make a good point. I think that it's a very good observation. Two things I want to say about that. One is that I showed you the whole thing in its entirety. So if you were going to be able to be at the beginning, say, this looks like it's a simple, it's a simple, it's not a complex thing. You would have a workflow that allows you to just put the basic information in. And then I think the coding of it is important. And if you want to add codes to that, that's fine. But I think also your narrative, you are dealing with the patient. You see that they say, yes, this is fine, but their face says, no, it's not fine.
Mm.
You are going to make that annotation on the text box. The text box shows up as a text box here, but there is a tool that attaches to this that is a voice recording. And that voice recording gets translated into text. So it's not check boxes. In fact, I won't go back to it, but I just went through it like that. But if we had some time to go through it better, you'll see that they're all text boxes. They're not check. There's some basic check boxes, like you want to know whether they have a surrogate or not. You want to know whether they're an infant or not. They want to know, some basic things you need to know that are check boxes. But the impression and the dialogue and your personal impression as a bioethicist is something that you're going to be able to record. You don't want to have the administrative burden that then you have to go back and remember what it is you talked about and do that. But you do want to have, kind of like you have in psychotherapy sometimes, or psychiatric consults, you want to be able to record that, but the patient's going to have to be okay that they're recorded. And then you want to be able to record that and to attach it to your consult. So you don't have to retype the whole thing. And that's, our tool allows you to do that. Does that answer your concern?
It
Yeah.
does. Yeah.
And I totally agree. Yeah. So many people, they're afraid to say something, especially if they see it's a doctor. They're afraid to say something, and yet they have a concern. And you can tell as a bioethicist that they have that concern. You can see faces. By even the discussion, they look at each other, right? They're looking at each other, saying, yeah, right? And so you can make that annotation. You can make that annotation, because that is a lot of what you're going to do to make sure that you can get buy-in. Yeah. Okay. Any other concern, feedback? And I think that one of the things that I want to do, remember, I don't know if you were here at the beginning, I had a picture of a five-wheel thing.
I saw it.
Did you see it? Okay.
Yes.
What we're doing is we're making that picture of the 5 things the entryway to the documentation, so that you can click on the one that you want. And then to the extent that people are feeling comfortable with voice activated things, we can do that, or we can tool, so you can go directly to where you
You're breaking up.
want to go, right? And you don't have to have the manual. Okay. All right. So anyhow, the five thing is the idea that we're going to be able to go with some icons that you can go directly to where you want to go. All right. Does that help? Yeah. Okay. All right. Anything else? All right. If you can always reach us at info at hccmc.org. I'm going to write it here. Info at, it's not HECMC, it's by, I have an identity crisis here. Okay. That's the website. I mean, that's the email address. This is my name. Any concerns, any questions you have, or if you want to have a trial period, or if you want to talk about your ideas of a mini version of this, and happy, it's all done here. We do it all here. Create special kinds of things for your organization. So let me know. Okay. And your input is always valuable because it adds to the general knowledge of what we have. It's great. Okay. Thank you very much.
BioEthx Café. Café BioEth.